I am so touched that so many people are here to the bitter end. So hopefully you're all going on this boat trip imminently, and we can get together and celebrate that, you have lasted this entire session. Now, I chose this topic, how to differentiate residual disease from treatment complications, because I thought there's a good point at the end of the day to reflect on the range of treatment options we have now for the cancer patient, and really look at what are common in at least my clinical practice, which is predominantly cancer related. And what I'm trying to do here is to sacrifice depth for breadth. So I'm going to go through quite a lot of areas of treatment options that we now are available in the clinic for the cancer patient, look at some of these common complications, and then talk through how I systematically think about in trying to differentiate whether something is more likely to be disease recurrence or residual disease versus the treatment complication. So first and foremost, I'd like to talk about the different treatment options and the associated complications. I want to talk a little bit about mechanisms of disease recurrence, and then try to take you through an approach where you can make use of, in a sort of practical way, of distinguishing between complications and disease recurrence, looking at a role of clinical information, conventional, and also more advanced imaging techniques. Now, in terms of oncological treatment, there are many. The patient can undergo surgery, we can administer chemotherapy, radiotherapy, and now increasingly also radiolabeled therapy. This is also called internal radiation treatment, and also minimally invasive therapy. And each of these options are available to the patient depending on their tumor type and stage. So the general principle of surgery is that if the disease is early enough, we hope to be able to remove all the surgery, and then the patient is effectively cured. And associated with that are common complications, either acute or sub-acute. So by acute, we mean that usually within immediately after the surgery, up to about 3 to 6 months maximum. And we can be dealing with things like infection, and typically you're looking at a cavity. If it contains air, you're more confident that you're dealing with something infective. The cavity wall tends to be thickened. And then there's hemorrhage, typified by either high density on CT or high T1 signal, representing that it's acute. And then, of course, if you're in the abdomen, you can damage adjacent structures. If you're doing liver surgery, you may have a collection below the subhepatic space, such as a myeloma. If you're doing lymphatic dissection, then you should be aware of the possibility of lymphocytes. These typically get smaller or stable over time. And also, if you're looking at bowel anastomosis, you may actually have bowel leak because the surgeon, may not have been so successful in putting the two bits of the bowel together. Now, another big group of surgery that you always need to think about are the patients that undergo some sort of organ transplantation surgery. So the largest group by far in our institution are patients who have hematological malignancy that undergo some sort of bone marrow transplant. So here we have a picture of STIR imaging of a patient with acute lymphocytic leukemia, showing areas of leukemic infiltration. And here, another example of organ transplantation, a patient with relatively early stage HCC may be chosen to undergo liver transplantation. Now, acute and subacute complications are largely common, but you must remember that you are dealing with a solid organ. There is a vascular supply that may be damaged, and this may be either arterial or venous. And chronic organ transplant complications are things like graft versus host reaction, for which the manifestation may be protein, and the common ones that you need to think about occur in the lung, the GI tract, and also the liver. So bronchiolitis obliterans may occur, and you may see evidence of airway dilatation and airway thickening, as well as air trapping. And in the gastrointestinal tract, this is quite common. You see non-specific thickening or diffuse thickening of the bowel wall, and also in sclerosing cholangitis. I haven't got an example here, but you can also, on MRCP examination, look for the characteristic intrahepatic biliary strictures. A condition that you do need to think about in a patient who has survived a long-term organ transplantation is PTLD, or post-transplant lymphoproliferative disorder. And this is something you should always think about, particularly when they suddenly present with localized or diffuse lymphadenopathy. Now, when it comes to oncological chemotherapy treatment, you've heard that many of the chemotherapies that we've been using are increasingly being replaced by the so-called targeted treatment. And this is what Richard was alluding to, the so-called ABs and the IBs. I just want to add to that information in your mind that, as they said, AB refers to an antibody, and these are agents that act on the outside of the cell membrane. So they target something that is on the outside of the cell. Contrast that with the IBs, which are really small molecules that act within the cell, so they're intracellular, and they affect some sort of chemical pathway within the body that relates to the cell function. So if you imagine that you're able to target the various targets either on the outside of the cell membrane or inside along the cellular pathway, then that will affect cell proliferation, cell survival, the presence of angiogenesis, or the sensitivity of the tumor to chemoradiotherapy or radiotherapy. And this is a very short list, and the point being that, increasingly FDA and other medical agencies are approving a huge number of drugs which are now coming into the market for the improved treatment of patients. Many of the drugs have lower complications, but there are many complications associated with these that you should be familiar with, particularly if that's your area of expertise or interest. So if you're going to be a GI radiologist, just be familiar with the range of drugs options that are now available in the clinic. And there's probably about 2 to 3 new ones being introduced every year. At least in my practice, we get that sort of number being tested or trialed. And in terms of clinical trial, we'll probably get about 10 to 20 new drugs a year that we have to be aware of the potential action and how that might affect the patient. So you've heard from Richard very eloquently about all the potential lung complications. So what I've highlighted up here are, for example, the condition of interstitial pneumonitis or fibrosis, which is very common. And the drugs in white are the common chemotherapies, but you can already see from this list that they are the ones in light yellow are showing those targeted therapy that can result in similar features. Now, steatohepatitis in the liver is very common. It's associated with common cancers, such as colorectal cancer. And it's not uncommon that if you treat a patient with colorectal metastases, as this example is, you will end up with diffuse hepatic steatosis that may actually obscure the underlying metastases. So we really have to think about how you might want to follow up these patients as they develop steatosis in the liver. And then, of course, the liver can also affect the liver parenchyma, as in any chemotherapy can, and you can get this shriveled appearance of the liver called pseudocirrhosis. That should not be mistaken for disease progression. Now, if you also have colorectal cancer, you may be given this drug, which is common, oxaliplatin, which is part of the FOLFOX chemotherapy, and they can also result in the so-called sinusoidal obstruction syndrome. Increasingly, we also see this in patients who are given selective internal radiotherapy, or SIRT. And as you heard from Kiran, they can also occur in children as a result of post-transplantation. So one of the key development in imaging is that if you use a liver-specific contrast agent, you can look for this typical, You can look for this typical lace-like appearance of the hepatic parenchyma in the hepatobiliary phase of contrast enhancement. So neutropenic colitis, Kiran has talked about it, so I won't bore you with too much detail. And the one complication that we see quite a lot in adult receiving bevacizumab is bowel complication. Reportedly, it's only about 1%, but we definitely have more than 5 cases a year at an institution. So I do think that the incidence is probably a little bit higher. So a strong clinical vigilance in susceptible patients is required. Now, if you look at PET CT imaging, for example, sometimes you can also get a flare phenomenon as a result of therapy, chemotherapy. So in this example, you can see 2 lymph nodes showing uptake, but after the treatment, you get this diffuse bone marrow uptake, and that's related to the chemotherapy effect, so not to be mistaken with as disease worsening. And in the brain, this is something that we do see occasionally, especially with patients on TKI treatment and also bevacizumab treatment, is the so-called posterior reversible encephalopathy syndrome. And these patients present with a change in the mental state with or without focal neurology. And typically on the brain MRI, you see area high T2 subcortical white matter signal in the posterior circulation, typically in the occipital or parietal lobes. And just as a fascinoma, this is really uncommon, but it has been reported. I just want to show an example of a potential skin complication. And patients receiving this drug, which I'm not going to try to pronounce, may develop this nodular panniculitis, and that should not be mistaken as a skin metastasis, because it can be prescribed for patients with malignant melanoma. And very quickly, you heard from Richard this morning about pseudoprogression in patients on immunotherapy. I just want to make the note that it can occur in the lung, and in fact, we often, when we do see it, tend to see it in the lung. You get new lesions in the lung, or lesions getting a little bit larger. And this is not due to the disease itself, but because the T cells has infiltrated into the tumor, or you get clusters of T cell going into the lung, and with time, they actually resolve and get better. Now, radiotherapy, this is something that has really developed quite rapidly in the last 10 years, so much so that nowadays in the clinic where patients are receiving what is called stereotactic body radiotherapy. Well, what that means is that if you have a tumor, what they would do is put a fiducian marker into that tumor, and then the X-ray source is varied in its position and intensity, so that you create a homogenized or a contoured map that is centered in the tumor. So the idea is that you can intensify the dose that is going into the tumor while minimizing the dose that is going into the normal tissue. And again, complications of radiotherapy, well-known radiation pneumonitis. Just to let you think about it, one thing to point out is that because increasingly there is this drive towards hypofractionation, what that means is that the radiotherapists are trying to increase the dose of each radiation treatment, because they are more confident about the borders of the tumor. Okay, so because of the increase in the dose, they can give fewer fractions. So biologically, it makes sense for them. But one of the things that we're increasingly seeing, at least in the brain, is the so-called pseudoprogression due to radionecrosis. So typically, from 1 month to 6 months after therapy, you'll begin to see areas of increased enhancement or apparent enlargement of the tumor area, but without a change in therapy, you can see that actually settling across time. And of course, you can have tissue fibrosis, and that leads to parenchyma distortion that is apparent on CT, or on T2-weighted MRI. What is typical about fibrosis that they have very, very low T2 signal intensity. So that is usually quite a good clue, particularly in rectal cancer, where you often think, well, has the patient responded to treatment or not? And we always find that the T2 signal is quite a good indicator of, and the morphology of the tissue is quite a good indicator of fibrosis. So in this example, you can see the tumor shrinkage, and you're left with this band of low T2 signal tissue that was proven to be just bland fibrosis at surgery. Radiotherapy, you can get marrow suppression, and as I said, with SIRT, you have to think about the possibility of sinusoidal obstruction syndrome. And last but not least, minimally invasive therapy. This is usually now applied to liver metastases, lung metastases, and some people are doing that for primary tumor, for example, small HCC. If you are living in Asia, that's quite a popular therapeutic option, and also small renal cell cancers. Clearly, you can apply this sort of treatment by radiofrequency ablation, high-intensity focused ultrasound, or other sort of image-guided therapy. So typically, this is what you see, the post-ablative zone. What you want to make sure that is that the post-ablative zone completely covers the site of the original tumor. If not, you have to look very hard for the possibility of little bits of tumor being left behind. So make sure that the area, and when you compare with the pre-treatment scan, that it completely occludes or surrounds the site of the primary tumor. Complications such as pneumothorax and hemorrhage are quite common. And in terms of disease recurrence, I just wanted to talk you through how, after a therapy, we actually begin to see either residual disease or disease recurrence. So clearly, if your surgery, your minimally ablative surgery or radiotherapy do not manage to eliminate all the tumor, then you're going to leave a little bit of that behind. So inadequate tumor clearance is an important cause of disease recurrence. Then if you're talking about chemotherapy or radiotherapy, what you're saying is that yes, you hit most of the rogue cells in the tumor fraction, but then a subpopulation of cells will subsequently grow and then, results in clonal resistance and tumor regrowth. And of course, the primary tumor may seed tumor cells into the circulation of the lymphatic system, and that get carried to another organ and it grows. So in terms of surgery, in terms of inadequate tumor clearance, as I said, it can be as a result of surgery, minimally invasive therapy, or radiotherapy. So let's look at rectal cancer surgery, for example, and you can see that nowadays rectal cancer surgery involves the sharp dissection of the tumor along the TME plane or the mesorectal fascia. And so if you imagine that if you're going to leave any tumor behind, it's going to be at the margin. So this is usually where you want to look at potential tumor regrowth. So knowing the nature of the surgery helps you to look at where the potential site of disease is going to recur. So this tends to recur at the border of the resection or the treatment fields. Now, with radiofrequency ablation, it's the same. If you are looking at a post-ablative zone that is not completely covering the site of the primary disease, then you expect that where it is not covered, the disease may regrow, as is in this example. So here we have on the pre-contrast T1 imaging, you can see irregular shaped defect on T1 weighted imaging. And on the arterial phase, it's really quite difficult sometimes to see the area of hyper-enhancement, particularly in the colorectal metastases. And we are helped here by the diffusion weighted imaging that shows you the rim of cellular hypersignal and low ADC value that is associated with the disease recurrence. And of course, in chemotherapy, what we have also observed in the liver metastases, for example, is that when it comes to clonal resistance and tumor regrowth, they tend to occur at the site of previous disease. So here we have a couple of liver metastases in the right lobe of the liver. And about a year later, after chemotherapy, you can see that all the disease has gone away. So everybody said, hooray, this is great. But then 3 months later, you can see that the disease has come back, but pretty much at the site of the previous disease. So these are patterns that are quite typical of tumor regrowth in the liver. And last but not least, we sometimes might be dealing with distant failure. So sometimes what you see on imaging is that the primary disease is getting better, but actually the disease at the distant site that your treatment may not be actually working is resulting in further growth of the tumor at a different organ. Metastatic disease, yes, it can be in the nodes, in the organs, or in the bones. And the clue here is that you sometimes have to look quite hard for the presence of either nodal or visceral disease by really knowing the underlying prognostic factor or things that actually make these sort of disease more likely, so that you're extra vigilant when it comes to surveying this particular part of the scan. So in rectal cancer, for example, if you see extramural venous invasion, that is almost a certain prediction for distant failure. So you look extra hard to make sure that you're not missing that lung metastases or liver metastases. So these are little clues that will help you along. So we come to the main gist of the final third of the talk, is to give you some pointers as to how you can tell treatment complications for disease recurrence, and use the mnemonic pattern. So the pattern of, you have to understand the pattern of spread of the disease you are dealing with, so have a good biological understanding of that. You need to know the clinical findings, such as tumor markers. You want to know the type of treatment given. you want to know the timing of the abnormality in relation to the treatment, and you want to know the extent of disease, i.e. the stage and possibly the grade of the tumor before treatment. You want to examine the radiological features very, very carefully, and then sometimes you may be able to apply novel functional imaging to help you. So understanding the pattern of spread is actually cardinal in any good oncological practice. So if you have a right-sided colon, then you will know that the lymphatic spread from the right-sided colon is along the venous system to near the confluence of the portal vein. So you want to look higher up for potential nodal involvement. And this is typically where you might see further nodal relapse in the upper abdomen. So here you can see that this is just adjacent to the third part of the duodenum. Now, associated clinical findings, by that I mean a range of tumor markers that may help you in the disease types, but if the disease is not associated with the tumor marker, then unfortunately that's not very helpful. And then the type of treatment given, we've seen the range of potential complications, so you have a mental note of what these complications are associated with a particular treatment or a particular drug. And then you want to also look at the timing of the abnormalities, so whether it's acute, early, in relation to a particular treatment, or is it late, so they have a balance of clue. And I think what is really important is that you know the baseline TNM staging. You know you have the old films to look at where the disease was. I find that incredibly helpful, because if you know the extent of the original tumor, where the boundaries of the tumor were, then you have a better idea as to whether something you see is likely to be related to the primary disease or not, and also coupled with the treatment history. So there are two. So I've made this little column in my own sort of naive thinking, how I think about treatment complications versus tumor recurrence. So very often treatment complications are non-mass-like, although they can be mass-like, and associated with features of scarring and fibrosis. Tumor recurrence, they can be irregular margin, but when of a size, they tend to be mass-like, and it looks locally infiltrative. The treatment complications, when they are in doubt, if you follow them over time, they tend to be stable, or they can improve. And tumor recurrence often is a new finding, particularly if you see something new after 12 months of follow-up, you have to think that this is disease recurrence. The treatment complications tend to be, if radiotherapy or surgically related, be related to the treatment field. Whereas a disease recurrence, they can occur in the tumor center, treatment margin along the pathway of spread. So knowledge of the pathway of spread is really important. Then the MR features like low T2 signal on MRI, a sign of fibrosis, high and intermediate signal, and you may want to use other functional imaging to help you along, as I will show you later. That's also quite helpful. And then, of course, a bland, uncomplicated treatment-related complications, especially chronic, will show no or minimal contrast enhancement. And tumor may be avidly enhancing. So serial imaging is always helpful. Here we have a patient post-rectal surgery, and you can see that there may be a little nodule anterior to the right rectum here, but on follow-up you can clearly see that tumor growing. So when in doubt, you can do serial imaging. And then last but not least, when in doubt, we can invoke the more expensive test to actually help you along. And I don't know, I suspect in America, the expensive tests get done very early, whereas in Europe, we tend to wait a little while and repeat the imaging because of the access to some of these expensive tests. So we know that FDG PET can detect unsuspected findings, such as bone metastases, or disease in unenlarged or non-enlarged lymph nodes. Peritoneal disease is something that we can easily miss on conventional CT, but with PET now, and also diffusion-weighted imaging, we have a better handle of that. But beware of the potential pitfall, mucinous metastases. If you see something that is low density, it may not, it may be a MET, but it may not have FDG uptake. And of course, lesions that less than a centimeter may not have enough metabolic activity to actually show up on the FDG PET, so you still have to do further follow-up. Now, diffusion-weighted imaging, a topic that is something that is very close to my heart, but we use it quite a lot in our clinic. And just by way of example here, we can see that the area of recurrence adjacent to the anastomosis site in the pelvis, that is corroborated with the PET CT scan. So you're looking at aerial impeded diffusion. And sometimes, for example, in prostate cancer, particularly after androgen deprivation therapy, the tumor may be really difficult to see. That's why you need additional imaging to guide you. Here we can see the diffusion-weighted imaging and the choline PET, again corroborating the presence of residual disease. But diffusion-weighted imaging is without pitfall. Again, small lesions may be easy to miss, particularly in the lungs. And also mucinous tumors, they may not actually show high signal on the high B-value image. And of course, not everything that's low ADC value is going to be tumor either. So the history and in this case, the T2 morphology with air in the cavity tells you that this is likely to be a pelvic abscess with a very, very low ADC value. Perfusion imaging, yes, you can use perfusion imaging sometimes to help you distinguish residual disease, as in tumor tends to have very, very high perfusion compared with normal tissue. And this is just two examples from the prostate and the breast. So I hope in that short time I've shown you that understanding cancer treatment and the complications is important, and that in distinguishing disease recurrence from treatment complications, it is essential that you know the treatment history and the clinical findings or the corroboration. And careful analysis of conventional imaging supplemented with functional and molecular imaging provides optimal assessment. So thank you very much for your attention.